Uh, okay, welcome everybody to the New York ORS quarterly learning session. My name is Jim Hawley. I am a drug intelligence officer for New York, New Jersey, HIDA. I'm here with my partner, Lisa Warden. Um, Today we have a great presentation on situation tables. But I'm going to give you a quick overview of the overdose response strategy. First, it's a public safety, public health collaboration. It's funded through the Office of National Drug Control Policy and the CDC. And what it is, it's a two-person team in every state across the United States, the Virgin Islands, and the District of Columbia. We cover all 33 HIDAs, and our primary goal is to reduce fatal and non-fatal overdoses. And we do this really through three ways. First, by forging crucial partnerships, and that's a lot about what this call is today, bringing multi-sector partners together for a common purpose. It's also sharing information and pertinent intelligence. And then the third is helping to implement effective strategies, which we think situation tables certainly qualifies as. So with that, I'm going to just touch on one more thing. I want to bring your awareness to a bi-monthly call that the ORS national team holds. It's the Tactical Assistance and Threats Analysis call. That is the every other month on the first Wednesday. So then our next call is July 1st, Wednesday, and Lisa will be dropping a link in the chat. Please join us. We'll get quite a crowd there, have some fantastic speakers, and it's moderated by our director, Chris Yakum, and one of our senior analysts, Emma Kempton. So with that, I will turn it over to Lisa.
Okay. Just a second. Yeah, so we want to acknowledge our some of our partners too, that Jim highlighted some of the work that we do. And I just want to, as a key partner, across the state, there are other HIDA, New York, New Jersey HIDA DIOs and analysts that support Jim and I in our efforts around the overdose response strategy. And Val is the similar, this is, I want to say your name correctly, is the DIO that covers the Chautauqua region. He was instrumental in connecting us to the great work that is happening in Chautauqua County. So thank you, Val, for that, and all the other DIOs across the state that support us and get us connected to all the great work happening on the ground. So with this situation tables, we're really excited to have a nationally recognized speaker, Scott Allen from Cordata Healthcare Innovations, to talk to us about this model of situation tables and hopefully how we can do exactly what our presentation title says. Give me just a second to mute that. Is like how we can intervene before a crisis occurs. So we're really fortunate to have Scott with us, as well as this amazing team from Chautauqua County they'll be presenting together. And these we were able to observe their situation table, and I was very impressed with the work that they've done, the cross-sector work, and we thought this is going to be a valuable resource to bring to our New York learning session. So with that, I'm going to turn it over to Scott. And Scott, I'll stop sharing my screen in case so you guys can all do that.
Great. Can you see my screen there, Lisa?
Yes.
With the PowerPoint, please. All right, perfect. So good morning, everyone. My name is Scott Allen. If you can't tell, I've got a little Boston accent. I am from Massachusetts. I'm a retired police chief, police officer of 26 years. I was located in a community right next to the city of Brockton, home of marvelous Marvin Hagel and Rocky Marciano, city of Brockton. I'm right next door in East Bridgewater. I say in full disclosure, I served as a drug cop for the bulk of my career before I became the police chief. And the only tool in my tool belt for substance use was identify drugs and make arrests. And then it was a community partner, a mother in my community, that started a group in 2013 called EB Hope that really changed the trajectory of my career and the way I responded in my community. I went from drug cop doing drug cases to, hey, how do we use our front row seat in law enforcement to connect people to treatment, care, and resources? And, in my county, Plymouth County, we have about 550,000 residents. Because of the overdose crisis, like my colleagues and friends up in New York, we were overwhelmed in the Northeast here with opioids. And I can remember just all we did from 2000 to 2010 was either Oxycontin cases, then it became heroin, then it went to fentanyl. And I had countless families that I had to, do death notifications to and the journey. But when I got involved with this group called the EB Hope, I started to think differently. I saw that we had this ability to help connect people to resource and treatment. But as a police officer, I wasn't educated on it. So I started to immerse myself. And luckily enough, we have, Harvard University, Boston School of Public Health. We reached out to these experts and said, hey, what can we as police do to change this paradigm shift of just responding to deaths? And then it became mental health disorders. And then what do we do with the children when we go to these homes? We can't just do mandated, notification DCF. We need to do something else. So that's my quick-winded background. I retired in 2020, but I helped in my county with another chief of police, Mike Bertieri, who's my partner. He was the police chief in Plymouth, Mass. I was the chief on the other side of the county, East Bridgewater. In 2015, as we started to get involved in this overdose response, we started a really initiative. Someone that if we can just mute him might be helpful. We got involved in a co-response model that anywhere in the county, if you overdose, a plainclothes police officer, a recovery coach, clinician, social worker go engage an individual after an overdose or their family. But someone had to overdose and almost die, and then we would go out there. Organically, people started to call our police stations as chiefs and say, hey, my son or daughter will overdose, or they don't have an opioid issue, but they have alcohol issues. Can you help them? And we're like, of course we can. We started to do these at-risk referrals where we go out and engage them if they self-referred or referred by family members and loved ones. And then as we were doing this, our county model became a national mentor site through BGA. As we were doing this, we heard about this thing called the Situation Table. The first one was in Chelsea, Massachusetts. And for those that are familiar with the Boston Garden, and that's with an AHRDN, I try to take my accent out on that one. But there's a green bridge that goes over in the garden. At the other side of that green bridge is Chelsea, 2 square miles, about 65,000 residents, predominant Hispanic population. In 2014, they were the 11th most dangerous city in the country. They didn't know where to turn. They didn't know what else to do. So they heard about the Situation Table as this rapid risk factor triage approach, and they said, let's try it. And Chelsea quickly dropped outside the top 20, top 50, top 100 to address violence. But what they quickly learned, and what we learned, was that the Situation Table addresses all risk factors. It's not just a one and done for substance use, mental health, domestic violence. Anything and everything can be brought forward to the table. So when Chelsea started doing that in Plymouth County, we said, hey, we want one of those too. So we ended up getting the founders of the model out in Canada to come down to us in Plymouth County and trained us. And in 2018, we launched 4 situation tables. They now operate. I've been retired 6 years. They're still operating to this day. We actually just helped do a refresher training because the personnel change over. So we do refresher trainings because there is a structured model that I'm going to tell you about. Every table is 54 in the US, 120 in Canada. Original model came from Glasgow, Scotland. Every table operates the same way if they're following fidelity. We have a script. We follow the same data tracking mechanisms. I'll get on all to that. But the table looks at risk factors and it gets there before crisis, as you heard Lisa talk about. And again, we're tracking data. We're tracking de-identified data, and I'll share some of that data with you. And then you're going to hear from my friends and partners in Chautauqua, Sheriff Quattrone, Vito Randazzo, and then Steve Kilburn, who, when I tell you, they are one of the best tables in the nation. And I've worked with just about nearly all 50 of them at some point. There's 5 in Boston. There's 25 in Massachusetts, 15 in Kentucky. But if you follow this structured process, you'll see things happen in your community, your county that wasn't possible before then. You don't need any funding. So if you're sitting there and you're a chief or you're an executive director saying, hey, I heard Lisa say, I don't have the resources or the funding or the time. You don't need anything to get a table. After the initial training and onboarding, you're going to have representatives there day to day in their day-to-day work. So you don't need to hire people to run a table. what we're going to do is we're going to show you how to collaboratively respond more cohesively than you've ever done. You're going to break down silos that you didn't think were possible. It's going to address risk factors upstream, and it's anyone and everyone: schools, police, fire, EMS, corrections, probation and parole, behavioral health providers, treatment providers. Hospitals are a key. Our hospitals in the South Shore were the ones that got the funding for us to get trained in 2018, because they said to me and my partner Mike as chiefs, "Hey, chief, what are you guys looking to do?" We said, "We want to launch 4 tables, but we need to have the Canadians come down and train us." So they said, "Well, we have community health needs assessment dollars we'll use to fund you." The hospital saw the value because their EDs were and still are overwhelmed with people struggling with these community issues, but they had nowhere to turn. The table works upstream to reduce that burden. This is the quick background. I want to make sure I get through everything in my 25 minutes, so then my Chautauqua County partners can talk to you about it. I will hit on, like, Plymouth County, we serve about 550,000 people. We have 4 tables. Each table has a hub that has the surrounding towns that serve that one table. But each of the 4 tables are interconnected and talk with each other. So my table up in Brockton will talk to the Plymouth table, with the Hingham table, with the Wareham table. This is designed to be structured so that a table should go as far as the bandwidth of the provider network can serve. So that's why in Boston, they have 5 tables. I just did a retraining for them last year. They probably need 3 more, quite honestly, but they now have better coverage, because what you don't want to do is ask providers and treatment agencies to say, "Hey, I got to go to 5 more meetings." This will reduce your meetings. The table does meet weekly. When you hear that, I know you cringe, but you will see you'll condense your meetings into 1 or 2 meetings. You'll have your coalition meeting, and then you're going to get in your table meeting. And the table is action driven. We're not talking about stuff that happened 6 months ago. Do we have new situations? Do we have open situations? If not, let's go. We're going to be done. When Socket, Rhode Island just did their meeting, they closed 6 open situations, presented 3 new ones, and they were done in 28 minutes. This is action driven. The first table that we've been involved with, it was in Chautauqua County. I know my partners and colleagues up in Schenectady had reached out to my partners down Chelsea years ago and have a table, a hub up there as well. There's been a lot of strong interest from other surrounding areas. I met Jim and Lisa years ago.
Scott, I'm sorry. Scott, could I ask you to pause for a second? And I'm going to mute everyone, and then I'll ask you to unmute. That way we won't have this issue.
Yeah.
So,
Okay.
Yeah. Just give me a second. Okay.
All right. So I'm unmuted. Can you hear me, Lisa?
Yes. Thank you.
Okay, good. So the original DIO and
Scott, you're muted again.
yeah, I saw it. Yeah. So the HIDA connection with our model was very impactful with the PHA. So we would invite HIDA and the PHA down to our monthly coalition meetings and our tables to talk about trends, but we don't get into, we do that before the situation table meeting, and then we get right into the meeting script. And I'll talk about that in a minute. With the New York interest, we've been talking with all these agencies. Sheriff Quattrone, Steve, and Vito and I did a presentation this year at the New York Association of Treatment Courts, which prompted a lot of interest. Overdose fatality review boards are now seeing the value because they're looking at fatalities, but they now recognize, hey, if we could do something upstream to stop those or reduce those fatalities, so now the OFRBs can also work in sync or be part of that situation table. So the interest is there. Judge Elliott, who is in Rochester, I know I saw someone in Rochester with our county partners there in his county, which has now slipped my mind right now. I can't believe. But it's funny. Judge Elliott said the situation table is the one thing I'm taking away from the conference. Monroe County. Thank you. So now let's talk about the model. It is unique, risk-based rapid triage. Many of you in this room, in this call right now, are probably saying, hey, I'm already doing this. You're doing a high-risk task force. You're doing a case management. That is not what this is. It's part of that, but it's more enhanced instruction, and it feeds right into the work you're doing. It's going to bring together all those service providers in one room each week. We're going to address the needs of individuals and families, and actually location based. You could put forward a situation of a location, say a motel that has acutely risk situations happening regularly. You put the whole motel in, and then we put a team together for that. And again, think about the individuals that you keep on seeing coming through your doors, your team's been working with, but you just can't quite help get them there. Those are those individuals and families that we want to bring to the table. It is a multi-service model. It's got Fidelity. It's been around for 15 years. It started again back in 2008 in Scotland, came into Canada, and then into the US in 15, Canada in about 2010. Privacy, privacy, privacy. We're going to talk in the 2-day training about HIPAA, CFR 42. No one is going to be asked to do anything outside their professional requirements that you have to follow today. So if you need a release of information, you're going to get it signed, or we're going to keep it de-identified, and then that team will get a signed release of information. In our Vermont tables, we see signed releases 60% of the situations. We're going to focus on risks and incidents. And again, we're going to talk at the table de-identified, and there's a brief opportunity to share. Again, I would argue, and I was doing collaborative work before I even knew it, back in 1994, 95. And all my experience, I've never been able to break down silos more than I see happen at the tables. The tables become the group that everyone wants to be a part of for bringing situations, for reducing risk of harm, but also to build those relationships that you've been struggling to get. I constantly have people say, geez, your office has been across from me for 20 years. We've never met each other. And now they're sitting at a table together. So if you've been familiar with the SIM, the sequential intercept model, intercept 0 to 5, every one of those, there's opportunities to engage vulnerable people, unhoused, persons suffering from mental health disorders, persons suffering from substance use disorder, alcohol use disorder, still kills more people today than double the number of opioids. But every one of those intercepts, and it's great we can connect people, but something bad has to happen, right? So think of if you had something more upstream that could get to an intercept -1, -5. That's what the table is, and that's where the table fits. But then when those people sift through the cracks, if you have all the intercept people at your table, we can start sharing more information. Probation and parole is leading many tables up in Vermont. We've got fire EMS driving tables in Rhode Island. In Massachusetts, a lot of our tables are either public health led or law enforcement led, but it becomes that one umbrella we all can operate under. This is where the tables are. There's 54 across the country. It is, if you're questioning, well, is this a evidence-based practice? It has been recognized by the National Association of County and City Health Officials. I call it NACHO. I've been told it's NACO, and that was my little joke, but NACO recognized it. Our Panhandle, Nebraska table, which is public health led, in 2022 was recognized, peer reviewed as a promise and practice. In 2024, they were peer reviewed again, and now they are a model best practice. It is recognized across the country, across public safety, public health, and community partners as a model practice. So when we go to the table, we're bringing forward individuals, families, and locations that are at what we believe are going to be acutely elevated risk. This is the definition. We don't use a rubric to score a situation. The table operates through consensus, through your shared expertise. You're going to listen and you're going to hear a presentation of a situation, and then the group will decide through consensus, are we at meeting the 4 elements of AER? If so, we're going to put a team together. If not, the table's going to decline the situation, but more likely than not, there's going to be a provider in that room that will take that situation and work with that individual family. And again, it's got to cross multiple disciplinary service sectors, because if it only has certain risk factors in one area, SUD, for example, hey, that's a direct referral to the treatment provider. The table doesn't need to step in. The table steps in when it crosses all those service sectors. My mother's got like 5, she's 76, got 5 different things. She's got cancer, heart disease, severe obesity. She's got all these issues. I got to navigate 5 different doctors. None of them talk to each other. So think of that scenario. That's what the table helps that person or family navigate and makes it so that they're going to be more successful. 4 filter process. And I know we started around 11:08. I'm about 18 minutes in, so I'm going to get quickly to the data, but the 4 filter process. Filter 1 happens at your agency, any agency, behavioral health provider, community partner. To be at a table, you have to be a direct service provider, government, state, local entity, nonprofit. You can't be a local landlord that wants to sit and listen. You can't be the media that wants to listen, because we will share names, ages, and locations. So you have to be a provider or within that spectrum, but anyone can bring forward a situation, individual, family, or location. A situation gets presented at the table each week. There's a table chair that follows a script, and there's a data recorder that's recording the de-identified data. Everyone else is sitting there as a participant. We like to have a lead and a backup from every agency. You may not be part of an outreach team, but you're going to be able to speak to your agency and what you can provide for resources. And then you'll say, hey, that will be Johnny from my team. So filter 2 looks something like this. I'm the table chair. Does anyone have a situation? Yes, Lisa does for the PHA. I have a 20 to 29-year-old female that is suffering from substance use disorder, mental health disorder diagnosed. She is in the process of being unhoused, being evicted. She is a victim of crime. She has a victim of intimate partner violence. She has a partner that is justice involved, and they have 3 children that they share between themselves that are constantly thrown from school. That alone is a presentation. I'm now, as a table chair, going to go through the script. To everyone in the group that just heard that, do we believe that there's a high probability that harm is occurring in that home with that individual? We're all going to say yes. Is there a high probability this harm is going to continue? Most likely, we're all going to say yes. Are we crossing several service sectors? We're all going to say yes, because we're crossing at least 5 in what I just gave you. Now, if some of the table says, hey, I need more information, the table chair will say, can you provide a brief narrative to give some more information? And that might come up if someone says, hey, I don't think we're quite there yet, or I'm questioning why you're presenting it. That one is a ground ball, we say. So now the table chair is going to say, based off of that, do we all believe that we are at acutely elevated risk? We're all going to say yes, raise our hand through consensus. So now the table through consensus is going to push that to filter 3. 3 things happen. We can share limited information if allowed. We're going to put together a filter 4 team of who should be part of that collaborative outreach team. And then we're going to designate a lead agency. Now, only if you have a signed release or as a law enforcement partner, I can provide names and locations. Been doing it since the 90s on domestic violence. We've been doing it with our substance use providers. But if you need a signed consent, we say I have a signed release. If you don't, we keep it de-identified. So we have a signed consent. The name is Jane Doe and John Doe, 123 Main Street. Their children are Janie, Johnny, and Janie, 7, 9, and 11. That's if we have a signed consent. If we don't, we just keep it going. And the next thing that happens is who should be part of that filter 4 outreach team. The goal is to engage that individual and the family within 12 to 24, 48 hours of today's meeting. And it's not you want to be a part of, you should be, based off of the risk factors and that narrative. So that's going to be substance use, mental health provider, school resource officer, school behavioral health provider, probably the police department, maybe probation, parole, maybe intimate partner, domestic violence advocate. We now have a 5-agency team. At the end of this meeting, that filter 4 team, which now has a de-identified number of 2026-01, is going to meet offline to strategically plan to engage that person. The lead agency is going to be who? It's going to be Lisa from, the presenting agency. All right, we're going to expect a report back the next week. We call it an update. Now that filter 4 meets offline. Do we have any other situations? No, we don't. We're going to close the general meeting. The filter 4 team can stay in this room now. Everyone else is going to leave the meeting, and that team will report back to us. That way there, people that don't need to know aren't listening to what should be a smaller group. Sometimes the first goal of that group might be, I need to get a signed release with your 4 agencies on my release. Okay, let's do that. And then they strategically plan. The goal is to report back the next week. They're going to case manage for 18 months, 6 months, a year, whatever they need to. But the goal is, did we engage that individual and family? Did we reduce acutely elevated risk? And if so, we can close the situation, but that case management is going to stay open for as long as need be. 27 risk categories, 105 risk factors. Coming up on my time, so I'm going to push forward here. When you say that you want to create your own risk factors, I'm going to say no, because every table across North America uses the same 27 and 105. The average risk factors per situation is about 6 to 8 risk factors. So again, think of those multiple service providers. What I'm going to do is I'm going to pause. I'll talk about data afterwards, but I want my Chautauqua County partners to now tell you about their situation table. Sheriff, Vito, Steve, you guys want to take the floor? All right, we got Steve screen sharing.
There we
Yes.
go.
You can hear me okay?
We hear you, Steve.
Yeah, Sheriff Quattrone is going to kind of get us started, and then Vito and I will take a turn in kind of bringing what you've heard Scott describe kind of in its actual utilization at the local level.
Thanks, Steve. I don't speak as fast as Scott does, nor do I have that Boston accent, but we will get going. I was looking at the participants, and I see some law enforcement, different people. I think we all share this common theme that when a boss goes away to a training, they fear what they might bring back. So that's not really what happened with Situation Table, but it's similar. Through my career, like Scott, I enjoyed arresting people. I thought people needed to be arrested, and I still think they do. But what I had realized was that we were arresting the same people over and over and over again and not doing anything to really help them. I had an opportunity to study with Chuck Colson from Prison Fellowship Ministries for a couple of years. He really helped me realize that it's okay to arrest, but we need to be doing more. And I don't think there's much disagreement that the war on drugs has not really been a success. And I also don't feel that being too lenient on the drug problem has been a success. We need to be smarter on the drug issues and the crime issues. And so I presented, in truthfulness, we failed in our first attempt at doing this. And that would be on me. I hired somebody to run the program, and we weren't really sure where we wanted to go. We knew what we wanted to do, but how to do it. The project director we had at that point had different ideas. She left. Vito came on, Vito Randazzo, and kind of turned him over. As Vito says, I handed him a piece of paper, said, hey, this is what we want to do. And the program has taken off since then. Yeah. But I probably should have jumped in this first is want to kind of do a couple quick survey questions to see what you know about Chautauqua County. But first of all, have you ever been to Chautauqua County? And if you could just take a couple minutes there or a couple seconds to do the Slido survey, that would be great. I'm thinking maybe it's not working because I see no numbers coming. There we go. So almost half. I'm always surprised at the I don't know. Chautauqua County is there we go. How about we'll give the answer here in just a second, but can you name a well-known person from Chautauqua County? Okay, I'll take that.
Verna Hoover. Oh. Roger Goodell? Wow. Ah.
I'd like to say you hit the big ones, Jim Quattrone, Lucille Ball, Natalie Merchant. Roger Goodell, his family is from Chautauqua County. But to help you know where Chautauqua County is, we are the furthest west county in New York State. And we're really, if you look New York City to Chicago, we're almost in the dead center. We're about 420 miles from New York City and 480 from Chicago. Yeah, we are pretty much a rural county with a population of about 126,000. Yeah. As we mentioned, Lucille Ball is from Chautauqua County. 10,000 Maniacs. Maybe I should quiz y'all to see if you know who's in all the other band members are of the 10,000 Maniacs. Roger Tory Peterson. And does anybody know who this gentleman is? I don't see. It's Brad Anderson, the founder of Marmaduke. And then Robert H. Jackson from Supreme Court Justice, but he also ran the Nuremberg trials. So we have he's from the Jamestown, Frewsburg area. So our situation today was when communities intervene before a crisis occurs. And this starting survey kind of indicated it. One of our issues, I feel Chautauqua County has been a great county, has a lot of resources, but for many, many years we operated in silos. Sometimes it was difficult to access the services. And I'd like to say it's amazing how much work can get done when nobody cares who gets the credit. And so we have to work together. We have to be willing to reach across the lines and support one another and support our residents. And what really drove this home is when I had somebody released from our jail, sat in the park across the street, and I had a chance to talk with him. And he'd been clean, mainly because he was in jail for 11 months. But 3 days later, they found him dead on a park bench. And that was really as a result of him going back to using and not being able to connect with services. And that's why we, in my opinion, started the CARES, the Comprehensive Addiction Response and Evaluation System. And through that process, the situation table was developed. And so I want to turn it over to Vito, who's really been the driving force with this. Vito and Steve, they're the workers. I'm the cheerleader. So and I'll continue to be the cheerleader for the organization as long as we continue to build and support our residents in Chautauqua County.
Thank you, Sheriff. And again, my name is Vito Randazzo, and I'm the project director for Chautauqua CARES program out of the Sheriff's Office. And as the Sheriff was saying, he is correct. He gave me a piece of paper and said, "Here, make this happen." So a lot of my background, obviously, you're probably like, okay, well, I actually am not a cop. I don't work in law enforcement. I did go to school for law enforcement. So actually, my college degree actually is in law enforcement, criminal justice. And I initially went to school to actually pretty much like every other, to arrest people. And my career kind of took different turns, and now I'm actually helping people. I still want to arrest people, but I actually help people. So when I came to the Sheriff's Office and kind of building the CARES program, I came with years and years working in mental health, substance, case management, and human services. And I know one of the challenges that I recognized as a care coordinator, as a care manager, and then also as overseeing a program as well was, people that are in crisis and need and need services, you make referrals, and then like it takes 2 weeks or a month, or there's different layers and things to getting people that need services. And, and the thing is, when somebody's in crisis, they need services now, so that was kind of the premise to the CARES program, was really more about just referrals, but actually making connections. So we've been in operation for about 2.5 years now, and we've kind of evolved to where we are now, to these 4 core functions. Our first one being reentry and reintegration, which with that, we are one of our biggest pieces of our reentry is our reentry hub. It's within walking distance of our county jail. It's open Monday through Friday. And it provides a place for individuals that are released from jail to actually go there, and they meet with a peer, and are able to kind of get snacks, get coffee, wait for the bus to come pick them up, but also an opportunity to kind of make a plan, kind of their plan back into the community, get referrals, get connected to treatment, get connected to services. But more importantly, to me, the referrals are kind of a side thing. It's more about the connection that they have with the peers. I know when I started this program, I could have hired anybody I wanted. I could have hired social workers. And I told the sheriff, I said, I want peers. I'm like, because when people come to the jail, they're not coming to see Vito, but they will talk to peers who have lived experience, who actually can really relate to them. And that's been kind of our bread and butter of our program. And it shows. I mean, the program has grown from June 25 to May 26. We've had 270 individuals actually visit the hub, and that continues to grow. In addition to the reentry hub, we also do a collaboration with public health in the jail with the MAP program, where my peers go into the jail twice a week, meet with individuals that are on the MAP program, and then what the hope is that when they get out, they'll come to the hub and they'll reconnect. We don't just end when they leave. We also provide it's going to change in 6 months here next week. We provide 3 months of actually case management and peer support. The other thing we do under our reentry integration is also Ignite program. So we actually have under our program, we have a correctional officer who works as a Ignite program coordinator in the jail, and they provide daily programming in the jail, and they have barber classes, electrical, plumbing, food service. They also have an on-demand Ignite program, so individuals can actually learn works, develop these vocational skills while they're in the jail that they can use when they transition out. And the Ignite program is not just a Chautauqua thing; it's actually quite nationally recognized throughout in other jails. Our sheriff, is kind of spearhead to bring that to our jail here in our county as well, which has been very beneficial for the individuals. Our next section of our comment is our deflection and diversion. So as part of our program, I have a treatment court liaison that works with the 3 local treatment courts here, and that's kind of coordinating with the courts and the individual. A lot of times, kind of making referrals to treatment facilities and whatnot. And the work she does is she's great at her job. And we're averaging about 5 to 7 bed-to-bed referrals a month. So we really are, getting people in, they're being assessed, and really kind of, because obviously, jail is obviously it's there, but it's not a rehab. You know what I mean? So getting people the treatment they need and hopefully get them on the right road to recovery. Our third core and function, alternatives to incarceration, which really is our situation table, which obviously we've talked about today. And then again, because a lot of these individuals that come to the table, not only they meet the acute elevated risk, but they're also a lot of times individuals that are high risk with engagement with the CJ system and incarceration. So it's very complementary to each other. And then our fourth and final area is supportive housing services. We actually collaborate with a local housing program for 4 beds. And we have individuals that are placed in there, and they're required to engage in outpatient treatment. They have to meet a care coordinator, working on the recovery, and they also are meeting with one of my peers twice a month. So it really is intensive. It's wraparound services. And I can tell you from, the 2 individuals we have in there, I know one prior to going into the beds had frequent interaction with police, like multiple times in 1 week. And I can say, there's a long duration where we were able to reduce that, as well as another individual who was going to the ED every day, who also we've been able to limit that. So it does work. The program does work, and it's just kind of wrapping them in services. And I will say, because of the work we've done, and again, I know Steve will talk about some data points and things like that, but we're also able to kind of collect data and tell the story. Because a lot of times we talk about recidivism, we talk about all these things, it's kind of on a broad spectrum. We're able to actually tell them, like, from right to the bottom, saying, hey, challenges are housing, substance, all these things. And by doing so, we're able to identify where the gaps are, and then go after strategies to actually take care of those gaps. And thankfully to New York State and to DCGS, we were actually awarded a grant which starts next month, actually, where we're actually going to be based on the needs we found. We're actually expanding service, including starting a community outreach team, as well as collaborating with another shelter for bed placements for individuals that are sanctioned. So a lot of things good that are happening. But like I said, it's all data from driving this data. So like I said, I'm going to kind of turn this over to Steve, who's with our public health, and really kind of this again reinforcing this collaboration between public safety, law enforcement, and public health.
Great, thank you, Vito. And so my part here of the agenda is, as Vito has described, the kind of umbrella of the Sheriff's Office's CARES program and its various emphases. Among them is the Situation Table, which of course is our principal topic for this meeting. And maybe by way of, I hope, helpful introduction on my portion is to just kind of give a scenario, actually a couple of them, and just for the sake of, I think, recognition that these are the kinds of things that probably every person on this call has had some or maybe even regular experience with. For example, perhaps 30 to 39-year-old male with chronic schizophrenia has a history of being pretty stable when he's in an assertive community treatment or ACT program, but does poorly when not. He's been on probation and had other criminal justice involvement, although there's no probation currently, but he is in a situation where, given his mental health and substance use, he's facing an eviction from the housing that he has had for a few years. He's secluded, paranoid, and has extremely poor insight. One kind of a scenario. Obviously, details will vary that you may have encountered, but it's the kind of scenario, and I could give plenty more, I won't right now, but where typically a single agency, and sometimes a single person within an agency, it's really well beyond the scope of what they can create a plan for. And as a result, as you could imagine in just this and any number of other scenarios, as has been said earlier, the crisis has to occur before really the troops rally to come up with a plan. The person ends up committing a crime. The person ends up overdosing. The person ends up being evicted and ends up homeless on the streets. We've all done the kind of work in our different lanes long enough to be able to see a scenario unraveling. And you don't have to be a prophet to say, this does not look like it's going to end well. Those are the scenarios which come to the situation table. And so I really quickly just want to give kind of an overview. We are, as I think Vito mentioned, a partner in this from our public health point of view, and it's an excellent partnership that we bring both kind of perspectives onto these. So just quickly, Scott has already kind of covered what acutely elevated risk involves, but again, just by way of review, high probability of harm if something doesn't happen. In other words, as I often say, it's not going to end well. And it's so complex that any single agency really isn't singularly going to be able to come up with an adequate plan. So here's how it looks in our context. As Scott said, we meet, as others do in other situation tables, we meet every week, in our case, Wednesday mornings, 9 a.m. And typically, a meeting will last a half an hour. It's sometimes even shorter and rarely longer than 45 minutes. And that's because there's a kind of disciplined process, which we're going to role play in a moment, that moves the agenda along quickly. We are not there to solve the world's problems. We are there to put together, we're not even there to solve the individual's problems. We're there to solve, or rather really to create a team that can intervene upstream in this person's or family's life before a bad outcome occurs. In our relatively small and rural county, we've still had really good participation. We get 19 to 20 on average participants every week. We like to meet in person, physically in a site, but we recognize that there are some folks who are key to the table whose jobs really won't permit the travel time. So we do offer a hybrid version, but it's kind of selective who we sort of allow, if you will, to come in virtually, because we do see the value in being together in the same room. Nevertheless, between the two, online and in person, 19 to 20 on average. And over the first year, which we've just concluded, we've had 13 separate agencies in the county or government departments, separate unique agencies, sometimes multiple people from a single agency, but those are separate agencies who have been pretty regular in their attendance. Some of them even much more than 50% of the meetings, virtually 100%. But it does acknowledge that people come because they see value in what happens at the table. I genuinely believe people would not be traveling a distance, and I mean, half an hour in many cases, to sit at a 9 o'clock meeting for a half an hour every week if they did not see the value that we're able to produce. We've had 90 situations in that first year that we've just concluded, overall risk lowered in the vast majority of them. Doesn't mean the person's lives are all put together, as it were, but as Scott has said, that's not the goal of the table. We've been able to reduce the risk of a bad outcome. And that's been true in the vast majority. In fact, in the ones that it wasn't the case, it was typically the person just wouldn't participate, or we couldn't find them. So we've had good outcomes. These are the most common risk factors, and I would assume that in your context, those would probably likely be the top three also. And as Scott has said, it's really a kind of complex situation where there are multiple risk factors playing in. So our experiences are typical, complex situations, a lot of housing issues and behavioral health overlap. Thankfully, a high closure rate, meaning a team was put in place, they intervened, they reported back in a week or two, and the acute elevated risk was decreased. And then finally, we've enjoyed a lot of cross-sector participation from law enforcement to various CBOs to government agencies here. We also introduced what we called the strategy table, which is not really a part of the situation table model, but has kind of naturally or organically emerged from it. Quarterly, we will hold a second meeting on the same morning, so just following our situation table, at which we at least try to talk through some of the systemic issues which we see recurring time and again in the situations that we've been discussing. So, for example, transportation. Time and again, this is a barrier that people have to getting to the services that they need. So rather than try to only respond to those acute elevated risk situations, we're trying to think through how can we talk about systemic improvements, at least, that can reduce those barriers before they become a barrier. And it's also been a nice opportunity for us to kind of highlight the work of the table in the community. So with that, we're going to try something which we've not tried online, but did try on a couple of occasions in live presentations, namely to give you a sense of what this really looks like in action. We're going to role play a situation table. And we're going to pretend that all, however many are on the call now, are at the table. So there'll be a place where in the comment section, if you'd like, you could kind of pipe in your contribution to this artificial situation that we're going to review. So here's how the table would begin. We've convened at a established time every week. This is that time. Now, start the meeting. I'll chair it. Scott is going to be our data recorder. That's the only other really sort of role officially at a meeting. The chair or the facilitator and the data recorder. So I'm going to welcome you all to this week's situation table. Just confirm if there's anybody new here who has not yet signed the non-disclosure agreement that we expect every participant to sign once. Please do so. We'll get a copy of that to you. And now I'm going to turn to the data recorder. And my first question is, do we have any open situations? Meaning, do we have any situations that we covered in the previous week or couple of weeks?
Pulling up the online solution that I'll show after this role play, I find that we do not have any open situations, Steve.
All right. Thank you, data recorder. Of course, just as an aside, if we did, we would be getting an update on what was the outcome of the situation and the team that was assembled last week. How have they been able to establish a connection with the person and get services into place? So the next part here, and to kind of formalize this, as Scott talked about, this individual or this 4-filter process, excuse me. So now I'm going to say, do we have any new situations this week? Are any of the agencies bringing a new situation to the table?
Yes.
All right. And could you state your name and the agency that you're with?
I'm Vito. I'm with the Chautauqua Cares Reentry Hub.
Very good. And Vito, of course we know you, but do you have a consent for the situation that you're presenting to us today?
I do. I do.
Okay.
I have written consent.
Great. And is it a family or an individual?
This will be an individual female.
Okay. Well, give us a kind of thumbnail overview so that we can determine whether, as a group, as a table, we believe there's acutely elevated risk here present.
Right. I have a individual female, 30 to 39. Was just recently released from the county jail. Had actually come to the hub. That's how we interacted with her. It's got risk factors of mental health, history of substance use, obviously recent CJ involvement. She is homeless, and it did advise us she's sanctioned by DSS and also has some physical health issues.
Okay. Unhoused, is it temporary or is it temporary unhoused or has it been long-standing? There's two categories here. Okay.
Long-standing.
Thank you. And I'm just playing the role play of the data report.
Yeah.
So I'm entering this in as we're doing it.
Excellent. So again, as an aside, you can hear in the description that Vito has just given on the situation that even though he does have a consent, we're not getting any identifiable information. At this point, we're just hearing the picture broadly. So now I'm going to ask the entire table, and if you want to, you can comment in the chat, which would be your way of kind of voting, as it were, or arriving at a consensus. But I'm going to ask, do we have a consensus that there is a high probability of harm in this situation?
Steve, can we have a brief narrative? I lost track of that already. Can we just get a brief narrative, Vito, the background?
Yep. 30 to 39-year-old female, recently released from jail, is currently homeless. Has mental health concerns, has a history of substance use, and again, is homeless, is street homeless, and is sanctioned by DSS.
Thank you.
Do we have a consensus of a high probability of harm in this situation?
Yes.
Okay. And I hope we do, because the rest of the role play depends on that. But yes, I think we could say that. Another question, though, is are there multiple service sectors involved here?
Yes.
Yes. Again, self-evident in this case. And really, that's the process by which we, moving through what the filter 2 process now brings us to the filter 3. We have concluded as a table, and there might be questions, there might be pushback, or at least some...
Steve, do you just want to ask, therefore, are we at?
Yeah, okay. Therefore, are we at acutely elevated risk?
Yes.
Yes, this is the liturgy that the situation table brings to this. All right, so now we're moving into the filter 3, and we'll return to Vito and say, Vito, go ahead and, in light of the consent that you have, give us a name and some more details, and we'll see if there is recognition of this individual by any of the other parties at the table.
Yep. So the individual's name is Sally Joe. She is 32 years old. Like I said, she was released from the county jail for arrested for destruction of property. She was in jail for about 2 weeks, released, reported she'd been diagnosed with bipolar anxiety and PTSD. Prior to arrest, she was actively using meth and fentanyl, and is not currently connected to any outpatient treatment and or MAT. She said she was couch surfing, AKA living on the streets. She is sanctioned by DSS for non-compliance, and also reports that she has untreated ulcers on her feet and is not connected to healthcare.
Okay. Is there recognition from any of the other parties in the room? Yeah, Scott, you have history
Yep.
with Sally.
Yeah, we do from the local police department. I just looked in the CAD system and we've had some recent calls for service.
Okay. And again, at this point, we might hear a few people weigh in like, oh, yeah, you know, she used to stop into our drop-in center. We hadn't seen her in a while. Now we know why. She was in jail, et cetera, et cetera, et cetera. So it begins to pool some of both the history and then who has connections, a history of connections with, in this case, Sally. Are there any other services in place that we know of currently that haven't been mentioned? No.
No.
Okay, so now we're having kind of vetted it only at that level. We're not trying to figure out every detail about her life. We're going to ask now the question, who should be a part of the Filter 4 team? This is the team that's going to work together. Not that every member is going to directly connect with Sally, but they're going to be a part of the solution to get the acute elevated risk decrease. So you might even want to uncomment and just, you know, give an idea. What kinds of agencies ought to be a part of the team that responds to this situation?
Mental health. We got mental health in the chat, probation,
Yes, good.
social
Good.
services. Yeah. Housing.
Exactly.
Yep.
So we're going to get commitments from, you know, usually in our case, those folks are represented at the table. Sometimes they might not be, but so-and-so will follow up with them. Vito, can your agency take the lead on this situation?
Yes, we can.
Okay, so you will offline here, so to speak, off the meeting, after the meeting, you guys will convene, interact with each other, set up a plan, and move forward and be ready to report back next week at the situation table. All right, any other new situations this week?
No.
No. All right. Any announcements? Anything for the good of the community, just of any sort? No? All right. Well, folks, thanks so much for your great work. And the meeting will conclude. And you know, sometimes we'll have 2, 3 situations. Occasionally we don't have any. But the meetings are very short, very structured, and quite efficient. So
Yep.
that's
Hey.
that.
Steve, great question there. So how does filter 3 look like when you don't have consent? We just keep it de-identified, Margaret, the whole way. We never share the information. Keep it as what Vito said at filter 2. Don't share anything. We still put together the filter 4 team based off of the risk factors and the narratives. And then when we go to filter 4, when they meet offline, what will be the first thing to happen is, hey, I have a relationship. We need to get a signed release with your 4 agencies. It does happen, Margaret, where we keep it de-identified the whole way. And then the team's first initiative, we got to get a signed release so I can share this information. Is that helpful, Margaret?
Yes, very much so. Thank you.
Yeah.
And in
that was a
response
great
to the question about CPS, yes, they would be a very important. In fact, CPS, Adult Protective Services, Office for the Aging, you know, all of the ones that you might imagine would be needed at these conversations.
Hey, Steve, the other thing I'll interject is that I've seen meetings where one situation is an elderly or an aging population female with hoarding issues and medical issues. Then at the same meeting, there's a justice involved, at-risk gang youth kid that's had recent arrests. And then at the next one, it could be a person struggling with substance use or mental health. The beauty of this is that all the resources that can address all of those individually are there listening.
Yep.
In Rhode Island, 40% of the situations are 50 and older. Again, Chelsea started this because of violence, but now they've seen a big transition where they're working with a lot of juvenile populations. In Vermont, we actually had a situation table. We've had multiple tables now. Building principals are bringing forth situations. In Rutland, Vermont, the principal had no idea what the table was. He heard about it and said, hey, I think I have one of these things to bring to you guys. So we came to the meeting, building principal said, family situation, kids, blah, blah, blah. At the end of the Filter 14 being put together, he looked around the room and said, I was wowed by all the services that are in my community I had no idea existed. So I just want to interject a couple of those things. Steve, you guys want to answer? Because on those questions, yeah, syringe exchange for absolutely. Go ahead, Steve.
Yeah. And I mean, in our particular context, the syringe exchange program, which we have in the county, is fairly small. They're not really staffed to be able to attend these on a regular basis, but they've been very involved. And that's not uncommon in cases where you have a very cooperative, if you will, agency who is prepared to participate in the Filter 4 process, but may not be at many of the meetings. And that's our case there, but they're definitely involved.
And then for Renee's question, I'm going to have a slide I'm going to put up at the end, Renee, that if you're interested, basically, you know, we do these pre-mobilization sessions where we talk to start a situation. A table should be based off of those partners you typically work with, where treatment providers and partners are going to serve that region. Typically, that's where a situation table would start. Cities have, multiple tables by jurisdiction. Counties might have one table, but then some bigger counties might have multiple tables. Plymouth County, we have 4 tables, but again, they all talk to each other. So that is the beauty of this. How do you prevent the duplication of services? Make sure you're at the table, because at the table, someone's going to say, I'm already working with that person at recognition. And then you're not going to have another agency started. That's the beauty of this, is that by getting into the table weekly, you'll be more efficient in your collaborative responses. And what you'll find inevitably is you start working with partners that are working with your clients that you didn't know were working with them. And now you start that team approach. In our county, we had 6 treatment providers. I used to say all the time, we'd have a meeting with them saying, hey, everyone's got to play nice in the sandbox. So irregardless of what your organization's goals are, or to get increased referrals, our goal as a table is to make sure it's the right resource, not the one that's going to be able to do the Medicaid billing, et cetera. So those are the things that happen at the table as well. So it does simplify.
And I really want to drive the point. This really is a public health approach. It really, I know I've worked in mental health substance. Obviously, I know mental health side. I know certain OMH people are on the call. SPOA is a thing. You know what I mean? This is really not a mental health thing. It's not a substance thing. It's all encompassing. We could have people with no mental health, no substance, simply just a medical issue. You know what I mean? That it's a place for them to kind of navigate that. So I want to stress that this is really a public health. It's very broad and very open.
Yeah, that's a great point, Vito. That's why we always say, if you have a standing meeting that you're doing some type of case management, see if you can piggyback that. We have hospitals now that are leading the tables because they see the value for the hospital to be there. But every situation doesn't involve the hospital. You might sit at a meeting for 2 weeks and your agency is not a part of a situation, but then all of a sudden you have 2 or 3. Or, you may not be there weekly. You might be a secondary provider, but you go to the meeting once a month to let it remind everyone, hey, if you need me, you can always add me to your Filter 4s. Animal shelters are a perfect example. They don't go to the monthly meeting, the weekly meeting, but they're there to say, hey, if people will not go into treatment because they need somebody to care for the pet, put me on that Filter 4 outreach and I'll take care of the pets.
To Eric, this is great conversation. I'm going to see if I can address this excellent case, or a question rather, from Eric. The answer is some come from law enforcement. Some come, in our context, from the CARES program, because they're interacting with folks in the community, people coming out of the jail, et cetera. But honestly, the number of agencies that have brought a situation to the table is really quite broad. It can be anybody who's, in the course of their work, coming across these very complex, acute, elevated risk situations.
Hey, Steve, you know what? I'm going to pull up the solution just to show everyone what kind of information's out there privy to them. Are you seeing the database there right there, Steve?
We are.
All right. So I'm going to put in here, I should have had this ready. But I as that question came up, Steve, I thought it'd just be easy to show them because I'm going to go to that the place that shows them how many different agencies are participating. So you log in each meeting and you can see where they get. This is Chautauqua County. So they've had 101 situations since inception, and Steve's data mirrors this. 90.43 reduction rate in AER, 9.8 days to duration. That is when they're engaging people. The average situation takes about 10 days from the put that person. That's great data because that's telling us they're keeping them open usually no more than 2 weeks. So that's very critical. I'm going to jump to the question of mine. So Chautauqua Cares brings a lot of them. They're a natural fit, but you can see we're also getting them directly from the sheriff, probation and parole, Safe Lighthouse, Rome, the Mobile's crisis team. That's just who's bringing them forward. Now we look at who's the lead. Now, because Chautauqua Cares has those team members, they do take a lead role, but you also see they're working with the mobile crisis team. They're working probation and parole. The mental health associations involved as the lead. Safe Point Lighthouse. Again, this is real good data to say if we're not meeting the measures, well, who's missing? Why do we not have an X, Y, and Z agency? Now, who's assisting? That's part of a filter 4. Look at that. The Resource Center. DSS is the second most assisting agency. That's impactful because I remember in the training, DSS was like, I don't know if we're going to be there or not. They're now the second leading participating agency. Mobile response. So again, this is showing that diversity. UPMC Chautauqua is a hospital. So now the hospitals are seeing the value and the benefit to this as well. So a couple of other things, the highest risk factors, housing is number one. It is across the country, but I'm going to talk a little bit about more than like 2 minutes, Steve, because I want to hit on some of the systemic barriers that you guys are talking about. Substance use is up there, basic needs, criminal involvement, justice. So now make sure your probation and parole is there, corrections, reentry, mental health, diagnosed, suspected. That accounts, combine that's about 50% of the time. So your mental health providers or those agents need to be at the table because the situation data is showing these are the situations. Poverty, workforce development. Again, these are the types of things that come from looking at the data. Now, one thing, and this is a critique, is that Steve and the team and Vito doing a great job on individuals. We need to start doing more family engagement because they're so focused on the individuals. We see some tables that will have 30, 40% of these situations are family driven. So again, the data paints that picture. So I just wanted to show that real quickly for the group while we have other questions. And I'm trying to stop sharing. Did I stop sharing my screen? Nope. There we go. All right. Stop sharing. Sheriff and Steve, there's a question about law enforcement mental health referral system. I'd love to know more about that, Doug. And I definitely see how you can integrate and intersect with the table so it's not redundant. Are you able to unmute, Doug, or chat message? While Doug's doing that, I do have a couple of things I just want to show you on systemic barriers. So our partner up in Burlington, Vermont, as Steve was talking about that strategy table meeting, they did something very similar. But what they started to do is they said, you know what, we're reducing risk, but we still feel like these people are challenged or not. We're not meeting all their marks. So what can we look at differently? So what they started to do is they started to track, and I'm just flying through this. So they started to track all their situations. They closed the situation, but what were the recurring service gaps, policy barriers, eligibility challenges that they were seeing? So they started looking at this system approach. And what they found is that medical complexity was a big barrier. Mental health, poverty, behavioral, transportation was driving a lot of this. So they made these 5 categories, and now we've got 14 different subcategories. So it's not just housing, there's no affordable options, or more likely the barriers for some of these shelters are so high. So can we work with our shelters to lower the barriers? Or can we create a voucher system that's not as limited, that gives some more flexibility? Transportation, can we start to look at that in more detail? Transportation is a broader category, but they're looking at those subcategories. No transportation, no public access, poverty. Can we get some of our basic needs enhanced through a local hub center or things like that. So again, looking at the data in more depth is what these tables are now doing. What they found in 70% of the situations in Burlington, housing's the number one, but these are the drivers. It wasn't just housing, it was housing with basic needs, poverty, mental health, substance use, unemployment. So get your workforce development people there, have your mental health substance use providers there, and what other agencies work in these other areas, driver's licenses, etc. So I wanted to show that to highlight some of the great work that's happening because of that data collection. I know we got about 15 minutes left. Steve and Vito and Sheriff, other thoughts that you guys want to say on impact table before, afterwards? Other questions?
No, I'll just say real briefly. I think the table does work. I know there was a young, we think about obviously antidotes and things, and there was actually, I remember one of the cases that sticks out in my mind. It was we had a individual that was kind of similar to the scenario we used actually, but she was slightly older. She was sanctioned. She actually came from the local Code Blue shelter, brought her to the table, and we were able to kind of work with our local hospital, get her into inpatient treatment. We got her connected with services, and she not only removed her sanction, but actually she now has her own apartment and is doing well, from what I understand. So it does work. You know what I mean? It does work, and it's really amazing when like I always, Scott always jokes about, if you build it, they will come. And I always say, it takes a village to raise a child, but it takes a community to help people in need. And obviously, in 2026, we have a lot of people that are in need.
I saw another question, but if anyone wants to talk in the LMHRS, Doug there. Yeah, one of the things that I would offer is that this does reduce the duplication of services, because you get everyone out of their offices and their silos once a week to talk, because inevitably the meeting might close. Every table I've ever sat in or observed, I'll be up in Bennington, Vermont next week. They stick around for a half hour and they start doing additional problem solving. When Sauk at Rhode Island yesterday, there's like 3 little subgroups that now spawned off of that. So that's, again, that added value, like, oh, hey, I was thinking of creating this. Well, let's do it together instead of you creating something that is going to be duplicative. So hopefully Elizabeth, or I know that was Lauren had asked that. I would offer that. I have seen the table help to streamline. One of our colleagues in Brattleboro, Vermont, Justin Johnson, says, I used to have 12 meetings that were standing meetings. I now have 2, the coalition meeting and the table meeting. And then over those 2 meetings, all the other work flows from there. Any other questions? Or Steve or Sheriff, comments that you guys want to make? We've got
I would just conclude by simply saying, from our experience with this, and Scott uses this phrase, so it's not mine, but it really isn't, as you've probably already concluded. This is not rocket science. This is really very much. There's 3 things that I say that I think make it really work. It's consistent, it's structured, and it's accountable. And because it does those 3 things, it works. And it works by corralling the services that are already in the community and making them a lot more efficient and effective.
The other thing that, go ahead, Lisa.
Yeah, I was just going to add, well, people are thinking of maybe additional questions. So, as the ORS team, we're always interested to see areas of maybe gaps or needs. And, this conversation is making it clear there's a lot of potential interest around implementing situation tables. So we like to be able to bring partners together, like sort of in a community of practice, and maybe offer leverage technical assistance from those who are practicing this in, the state. Scott, I don't want to volunteer you for anything. I know your time is limited, but
yeah,
so we'll survey people after this call. We have a large network to see who's interested and talk further about building on this to help people launch their sit table.
Lisa, I did put a QR code. If they want, they can just put their information in there on that QR code. Do we have time to answer Valentine's question on the urban areas, or we got to wrap up?
No, we have time. Yeah.
Okay.
Yeah.
So Valentine, so the beauty of this is this works rural, urban, or suburban. So the city of Boston is about 750,000 people. I did 2 different trainings with them in the last 18 months. They have 5 tables. The city of Toronto up in Canada has 6 situation tables. Lexington, Kentucky, Louisville, Kentucky have tables. But I also work with tables in Southeast Arkansas that they don't have cell service for an hour and a half. Missoula, Montana is getting ready to launch next week. So this truly does work urban, suburban, rural. In the largest cities, like I'm looking at Buffalo, my advice would be is we sit down with all the key leaders in all the different sectors and say, let's get one group together to think about, population wise, service sector wise. Is it, Buffalo, maybe it's Buffalo 3 or 4 tables, but they all train together, they all launch together, and then they all piggyback one another. Like Plymouth County has 4 tables that basically covers 550,000 people. Each table meets, 2 tables meet back to back on Tuesday, 2 tables meet back to back on Wednesday, same in the same time frame, back to back, so they can address things together. And the biggest thing is you don't want providers to have to go to multiple tables. So that's kind of how the strategy part comes up with. I also there's another question there on AER. Now, yeah, so Eric, I get a lot of questions from my public health colleagues saying, well, do you use a rubric? Is there a Likert scoring system? No, we do not. It is that shared expertise. But we do get into details as far as that expertise. If someone does not think we're at AER, they will raise their hand and say, I don't think we're at AER. And then that's the beauty of this. Your professional expertise can then be shared within that larger group. It happened yesterday in Woonsocket. They put forward a situation. There was 3 of them. One got declined because it was a behavioral health provider that said, I don't think we're at AER. That sounds like that's something that, someone can, so-and-so can assist with. So again, it does share that expertise, Eric, throughout the rule. We don't use a screening tool that gets asked all the time. But I do see, I understand your line of question, but it is that shared expertise. The only other thing I'll add, Lisa, is that I don't want anyone to walk away thinking, oh, this situation table solves all the world's problems. It does not, but it does build bridges and fills gaps that people that slip through the cracks in agencies that are reluctant to, or just haven't been able to figure out how to work together. It enables all that. And then, as I said, like what we find in Kentucky, there's 15 tables, but each of those tables has a care navigation team. So they complement one another. That was the strategy that when I was the chief in Plymouth County, the table serves one purpose, the care navigation, the day-to-day outreach still happens. But now we've got a data set that you can't challenge. Like we just did a report for the state of Vermont where they're like, we've never had this type of measurable outcome data, but more importantly, the gap data. We see where our needs are. So now they're using that to go to the legislature for support and funding.
We have a few more minutes. Anybody, they can certainly come off mute or put it in the chat.
I guess, Lisa, I would ask either to unmute yourself or to put in the chat. Is anyone sitting at a table now or Schenectady here or other than Chautauqua, is there anyone else doing something like this, or you think you're doing something like this? A lot of times I'll get, hey, we do a case management and there's that built into it. But I also think that there's a way that case management can help integrate with the table so that we cover some more areas. Again, we get a lot of requests. Oh, hey, can we do a juvenile only table? Don't do that, because when you start to that, you're going back to silos. You're only looking at juveniles. When you look at just the juvenile, you're forgetting about the family member and loved ones, or some of those drivers of why those juveniles have needs and issues and risk factors. So that's why you want to keep it in one group, one room. Maybe you go a little bit longer. But again, a lot of times what I say to a table is, if you find that you're getting so busy that you're dealing with many situations, maybe it's time to branch off into subtables, but typically it's not. Even with a table like Woonsocket, that about 60,000 people in population, they had 6 open situations. They were able to navigate through one table.
Yeah, and I think, and it actually, me and Scott, we kind of, as we've been going over a year now, and we always talk about, like, now we've been getting mostly adults for the most part. We get families, but now we're getting kids. You know what I mean? And so that allowed us to evolve. So now, as part of that table, we went out and outreach to kid providers, saying, hey, we need you at the table because we're getting kids that are coming in. We want to be able to make sure we connect them with those services. So the table, it continues to, it evolves. It really does.
Yeah.
Yeah,
haven't
hi.
been. Go ahead. Yep.
This is Terry Tobin. I have a question. How hard is it, or how much success do you have in getting consent?
I can give you data. So in Vermont, they're getting 60% of the situations that sign consent. I can tell you that roughly 2% of situations get declined, either because of consent or they weren't, they weren't at that threshold. Consent is always the first challenge when we get in this training. It's usually like the first hour. I heard, okay, now we're not finding nationally. When we went up to Vermont, there was a state designated agency, HCRS. They're like, we need to be there, we want to be there, but we got to do it with signed consent. So I said, well, here's a waiver that a template, bring it to your legal counsel. They did. Within a week, they went back. Their legal counsel reviewed it and said, we need to add these 3 things. And now they're regularly getting signed consent. I'll even bring it one step forward to Terry Tobin. In Springfield, Vermont, the credibility of the table has grown in the public so much that some person walked up to a cruiser that was parked on the side of the road, knocked on the cruiser and said, hey, can you bring me up at the situation table? Now, the officer, unfortunately, didn't know about the table and got on the radio and said, hey, Chief, how do we get someone to the table? So, but again, that's we don't see HIPAA CFR 42 being an obstacle. And when it becomes challenging, we just keep it de-identified and we work in that smaller group. But consent, I find really across the country, if you ask, people will do it if you present it the right way and message it.
Do you have a template of how you present it to the person you're asking?
Would
you be willing to share that?
Absolutely. Yeah, we actually have Chief Burnham, Jeff Burnham in Springfield was one that created it. He said, hey, this is what I want to give to my officers and the firefighter EMS. So it's a half a sheet. We call it cop proof. I'm not sure. You might, if you're in law enforcement, you know what that means, right? We want to keep it simple, but it's a little half sheet reminder for the officers. Basically what they do is they say, hey, we got this thing called the situation table. It provides all these resources. It can help individuals, families for all these different areas. I can bring you up at this table, or my team can, if you're willing to sign here. Are you willing to do that? So I can absolutely share that with Lisa in the post training.
Thank you.
I saw Doug was unmuted.
No, I think it was a mistake. I don't have anything to add, but thank you. This is awesome.
Great. Hey, Doug, on your initiative, do you see that LEMHRS, you're working with vulnerable populations, you could integrate with a table? Or you're probably
absolutely. That's one of our biggest worries is law enforcement sends us these referrals and we never get to tell them what's going on.
Exactly. Yeah.
So this would be a chance for them to hear what's been going on with the referrals they've made and bring up any new people.
That's the beauty of having the de-identified data. What we do is we do a monthly newsletter for the sites, or the sites do it now. They run a report, they go through the system, they print it out, and then they'll look and they'll share a good little story. Hey, Officer Jones made 3 referrals last month. 2 of those referrals are still connected to services. We don't share anything that we can't, but again, those because the troops on the ground want to know if you're going to ask me to do something, I need to know if it's working. So again, that closing that loop is really impactful.
Yeah, that would be really helpful. It'd be good for morale for our officers to,
Yeah,
because they deal with the same people all
yep,
the time.
over and over.
Yep.
And I 26 years as a police officer, I had my naysayers over the time. We still have them. Even the most naysayer will say, hey, I saw this thing work and I'm going to use it again.
We got like 260 referrals last year, and there's only 36,000 people in the county. So
wow, that's awesome.
Yeah.
Great. Hey, Lisa, I see that I went over time here. Sorry.
It's all right. We're at time, but we've got really great discussion. We've also had, I just want to mention our follow-up. So we're going to consult with Scott and some of our partners at HIDA in the state, possibly to talk about follow-up technical assistance calls to support communities. And we've had some partners ask about this Lemurs program too, so maybe we can integrate that into our follow-up. But thank you, Scott, Sheriff, Vito, Steve, amazing presentation. We're so grateful for your time and the lessons learned and the sharing. We look forward to staying connected. And for everyone else, thank you for joining. And you know how to reach us if you have any questions or issues, but we'll be in touch.
I'll just chat in there. Go Red Sox, Patriots, Bruins, and Celtics, right? We're all Boston fans today.
Thank you. And for the Knicks,
Bills,
go Knicks.
Go Bills, go Yankees.
Hey, I'm glad New York got one. That you guys.
Go Bills.
I was
Oh my
actually
God.
rooting for the Knicks. I was actually rooting
We
for the
finally
Knicks.
did it.
That's funny. Have a great day. Thank you.
Thank you.
Thanks, Scott.
Thank you.
Bye-bye.
Thanks.